Hello, everybody. Welcome to the MIDAS webinar in February. I'm Wilbert van Panhuis. I direct the MIDAS Coordination Center. We have a very special webinar today, which is also the start of the 9th annual conference to increase diversity, mathematical modeling, and public health. That's organized by our Coordination Center and also in collaboration with the Harvard Center for Communicable Disease Dynamics. And so it's really my pleasure to host this webinar. Just for those who are maybe unfamiliar with MIDAS, MIDAS is a global network that is dedicated to modeling of infectious disease dynamics. The network is open to researchers, professionals, students, and other scientists, professionals interested in infectious disease modeling. And the network has grown quite a lot in the recent year. A lot of MIDAS, of course, is working now, many people on the COVID-19 pandemic, but also many other topics. And the Diversity Conference is traditionally, this year is the 9th year, but for the first 7 years been organized by the Harvard Center for Communicable Disease Dynamics. And the last year we have joined them as the coordination center. So today we have two speakers. One is Rodlin Pirilis, who was a participant in the diversity conference a couple of years ago. Last time we organized it in person in Boston. And the conference is to bring undergraduate students from underrepresented groups together and teach them about infectious disease modeling and the different methods used, and expose them to different methods, and also build in some career growing and trajectory recommendations and exposures. This year we have a very nice setup of people from the MIDAS network who are coming and talking about their work and also teaching today, tomorrow, and Sunday. We have a career panel with people from CDC, from the industry, and also from academics. And we have a great group of 37 students this year joining us. And so we're very grateful for the organizers and for all the people that are behind the scenes and the volunteers to help with the groups and with the teaching. And then the second speaker is Dr. Caroline Buckee, who will talk about the relevance of diverse perspectives in infectious disease modeling. So first I'll introduce Rodlin, who will talk first and give her some sharing her experience of her time in the diversity conference and how it has helped her, only briefly, and then also maybe say something to the people who are currently joining the diversity conference. A lot of the students are joining the webinar today. And then Caroline will give her talk. So Rodlin was born in Arbanite, Haiti. She left when she was 9 years old with her family. She completed classic school training in Miami, Florida, obtained her bachelor's degree in science and behavior neuroscience at Nova Southeastern University, NSU, in May 2019. In the end of 2019, we organized the diversity conference and she joined at that time. During undergraduate years, she has presented multiple posters, co-authored a paper as well in the Journal of Exercise and Nutrition. She's also since then been working at NSU as a research associate in the Department of Periodontology, studying platelets in patients with periodontitis. And now she's also a master's student at NSU Allopathic School of Medicine, where she is pursuing a master's of biomedical science. I'll also introduce Caroline at this point so that we can move on to her presentation without further ado afterwards. We're very, very grateful to have Caroline talk with us today. She's an associate professor of epidemiology at the Harvard School of Public Health. She's also an associate director at the Center for Communicable Disease Dynamics and has been really helpful in organizing this diversity conference over the last years. The Buckee lab that she's leading uses mathematical models and data science to understand mechanisms driving the spread of infectious diseases with a focus on pathogens like malaria that affect vulnerable populations. She received a DPhil from the University of Oxford, did a postdoc at the Kenya Medical Research Institute, working on malaria, and also worked at the Santa Fe Institute, also on malaria, evolution, and ecology. And then since 2010, she joined Harvard as a faculty there. And of course, she's also been very dedicated and interested in issues around diverse perspectives for infectious modeling. So we're very happy for her to give this this lecture to start off the diversity conference. And also we're happy for so many people of the MIDAS network to join us also around this webinar. So with that, Rodlin, would you please tell the people what you experienced and what you would say to the other students?
Hi, hello, good morning. Good morning. I hope you guys are having a great day. Thank you, Mr. Wilbert, for the introduction. So I would like to first start by just giving you a little background about myself. Just like Mr. Wilbert stated, I'm Rudlin Peerless. I was born in Haiti, moved around quite a bit, to find stability. And then finally we settled in Miami, Florida. And then I attended school there. And then I started my undergrad at Miami-Dade College in Miami, Florida. So anyone who's in that area, I started there at Miami-Dade and I transferred to NSU where I completed my bachelor's in behavioral neuroscience. And that's when I started. So I attended the conference twice. That's why you saw the latest one. So I started when I was just a sophomore to junior in college. And then the first time it was a great experience. I am not saying it just because people are there visiting, but because it was a great experience for me. Because not only I saw snow, but then it was the whole environment. It was dedicated to helping students like me. First of all, even though like the material at that point was kind of heavy because I was just a sophomore in college and I'm learning like mathematical modeling and I'm like, what is this? But they took their time and not only did they present, but they took their time to answer our questions, whether they were very simple to them, but to us, it was like, we're trying to understand what you're saying. So my first time was about 2017. So my first time attending it was 2017. It was great. I got to meet people like Jermaine. He was he was like one with a diverse background, yet he's still interested in research. And I encouraged a lot of my peers to join me as well. And all of them stated the same thing. They had a great time. And my favorite thing about that year was how we got to network. We met different professors. We met different people from different backgrounds. We met people from academia, from private working. So we met a lot of different people. So I was happy. So I was like, you know what, I have to come back. This year was not enough for me. I have to come back. So last year in 2019, I believe, 2 years ago. I said last year because 2020 is a blur. 2019, I came back again. It was awesome. Then I was able to understand better. So my first year the truth is, it was hard. It was a hard concept because I was not used to it. Being from a minority, from my area, research was not something that was, common in a way for me. It was not common. I did not know about mathematical modeling and seeing all these great things. I was not used to it. So going there for the first time, it was heavy for me. That's why I said, I have to come back so I can actually kind of consume everything and properly understand it because of my time of experience as an undergrad. So I returned, I was able to understand it more. I was more engaged. I understood when they were showing me, and I see how that came into benefit in 2020 with epidemiology and how spreading of diseases. I was like, when we were there, we were like, okay, that's nice. Oh, it's just cool. We get to play on the computer and see how diseases are spread. But then living in it, I'm like, oh, makes sense. That was very beneficial. So I very much appreciated that. And because of that, because of the time that I spent there, I realized I actually want to continue this. Even though that was my first serious exposure to research, I want to continue it. So from there on, I decided I was always a pre-med major. Till this time, I'm still considering, medical school. I'm still considering doing clinical. I'm doing clinical, but also I've been inspired to follow research because it's something that I'm very passionate about, and that is why I continue with my master's. While I'm getting my master's in biomedical sciences, I'm also working full time in the Department of Dental Research, and so being able to combine my love of medicine and research was a great deal for me. So I very much appreciated the opportunity that Mr. Wilbert, Jess, Miss Stephanie, all of them provided for me. I want to let you guys know that it was not something simple. it was not something simple. I benefited from it. I loved it. And sadly, I'm like a master's student. I can't join again, but I would encourage everyone who wants to come with an open mind. Come with an open mind that you may like it. Like, I never thought that we would be using social media as a way to collect data. That's one of the things that captured I'm like, oh, so every time I use Facebook or what I like can be used as data to better the people using it. So I love that. I love that part. So I want to encourage everyone who's listening to me right now, if you're doubtful about it, like, why would I like something about mathematical modeling? It sounds like things for only super smart people. But I would encourage you to do is join. You will see how it opens your mind. It gives you you have a broad perspective. You understand things better. It's like, it will make a difference. All I could tell you, it will make a difference in your life, because I would never thought I would like something like that. And I joined it and I loved it. And I wanted to stay attached to it. As you can see now in 2021, and I'm still attached to the network. I'm still there with the whole group. So I would encourage you guys to join if you can. And that would be it. If anyone else has a question, if Crystal will have any question for me, I'll be here.
Thank you very much, Rodelyn. Really wonderful to hear how it has helped you and inspired you to do research and bring it into your career. Let's see if there is a question or anybody. This is a bit of a ad hoc, but if there's anybody that wants to pose a question for Rodelyn, we can have a question. Raise your hand, or because we have to unmute somebody to do that, or type something in the chat later. Rodelyn will be around for a little while to answer questions through the chat. Okay, I don't see any hands right now. That's okay. But I really appreciate it, Rodelyn. Oh, there's one person. Harry has a question. Okay, allow him to talk. Go ahead, Harry. You can unmute yourself. Oh, I can unmute you. Let's see. Ask to unmute. Yeah.
So I guess the question really is sort of a broad one, but how do we encourage people like you who may not have thought about doing this sort of work? How do we encourage folks to get involved and to try to jump into places that they might not have been aware of or might not have thought of jumping into?
Thank you. I would say, like, for me, how did I get introduced to the program was because I attended a summer program for medical students. And then after the summer ended, they updated us on emails. And the thing is, they give you one thing that program did, it open our mind to want to experience things. So the first thing I would say to encourage anyone is to bring people like me to areas that once they see, because the reason why I was interested is because someone that with a similar background as me introduced me, told me something that you might be interested in. So I would say, if it depends on the group that you're trying to encourage to join, you would bring someone with a similar background where they can relate to. So it's not just someone that they can't understand, they can't relate to, but someone that they can relate to. Then maybe they say, well, if that person liked it, I would probably like it. So that's one thing I would say, is encourage them by showing them people that did it that's similar to them in a way.
Great, thank you. Yeah, and that's things like that we can definitely use to build our outreach program as MIDAS and as institutions teaching modeling and quantitative methods. Thanks a lot, Rodelyn. You'll be around with the chat and then go off to your class. It'll be great. It's great to see you, and I hope to stay in touch.
Thank you.
Thank you. And now it's my great pleasure to hand over to Carolyn Buckee to share her insights. Thank you, Carolyn.
Thank you, and thanks so much for your comments, Rodelyn. That was very inspiring. I hope we can encourage more people like you. So I'm going to talk today. The title for the talk that I shared was Introduction to Infectious Disease Modeling and the Need for Diverse Perspectives. I should caveat this by saying that I am not an expert in DEI programs or diversity and sociology in general. So I'm speaking about this from my own personal perspective on our field and why I think diverse perspectives are important. So I'm going to start off by just kind of introducing infectious disease modeling, how we use it, the kinds of applications. And then I'm going to talk a little bit about how data and models can help us to understand mechanisms driving inequality and dynamics of diseases in different places. And then at the end, I'm going to talk a little bit about kind of diversity in general in the field and in science. So I'm going to focus on COVID-19 because I think that's top of mind. And as Rodlin said, you know, I think before 2020, a lot of my students would be like, okay, SIR models, but like, what is the, like, how can you actually use them in the real world? And I think COVID-19 really opened this up to a whole new group of people. And I'm hoping that we can use this awful pandemic to help us interest people in trying to learn more about what they can do. So before I start, I want to thank my group. This is just a handful of my group and former group members who I've worked with over the years. And I think it's important to really stress that we often see scientists in the media and they are portrayed as lone geniuses who have figured out something on their blackboard and discovered everything. And that's not actually how science works. Science works in teams. It works through collaboration, especially public health research, collaboration not just between industry and public health agencies and academia, but also within academia. We need scientists of all different kinds, and all of the papers that I publish and the papers that my peers publish are the result of a group effort from collaborations and discussions with a whole bunch of people, and everyone has their role to play. So I think that there's a, part of this diversity issue, and part of the reason people feel excluded is because we don't portray how science works truthfully in the media, and that's something that needs to change. So I just want to acknowledge my team here. So to start off, I'm just going to walk through the way I think about how models are used. And this spans the spectrum from basic science all the way through to making policy decisions in the real world. So one of the ways that we can use models is to try to understand mechanisms by which diseases spread. So here's just an example by a group at CCDD. And we want to ask the question, what is the expected transmission dynamics of this disease if you make different assumptions about how seasonal it's going to be and how long immunity lasts, for example? So it's a very simple model. At the time that it was developed, we didn't know much about the disease. And so it was kind of a what if experiment, right? Where we want to know, okay, let's assume some things about this infection and then ask what could the long-term outcomes be for this kind of pathogen. Another way that we can use models is to try to estimate something important. So this is just a picture from a study from Ebola data in Liberia in West Africa. And here, one of the questions could be, how transmissible is Ebola during this epidemic? Or how do we think the epidemic might progress given how it's spreading right now? And this parameter, the reproduction number, or R0, is something that you may have been introduced to through the media last year. The basic reproduction number is something that we want to estimate because it tells us how likely a disease is going to spread and how bad an epidemic might be. And then there's forecasting, and that's something that gains a lot of press, but it's a subset of models. And here we're trying to make specific predictions. How many deaths from COVID should we expect next month, for example? How many hospital beds will I need in Louisiana in April? Those kinds of specific predictions come from forecast models, and they have their own sets of limitations and constraints and possibilities, but they are, again, a way to try and understand what might be coming down the road for public health agencies. And then some of the models that I use a lot in my work are working with public health to try and understand how to allocate resources effectively. So in many cases, public health agencies are working with data from around their country. So this is a picture of the country Bangladesh in South Asia. And you can see the distribution of malaria burden. So I work on malaria mostly. It's a vector-borne disease, and it impacts mainly rural and poor populations. And you can see in Bangladesh by this heat map, most of the malaria is in southeast Bangladesh. And so the government needs to have a way to take data from clinics and hospitals, map it out, and figure out where they're going to put bed nets, where they're going to make sure that they're sending treatment, how they're going to reach the populations that need that medicine and need those interventions. And so we can use models to try and understand how best to allocate those resources, as well as making sense of surveillance data. And this piece, the making sense of surveillance data, is critical. And I'm going to talk about this more, but this is where both understanding what resources you have and how you want to allocate them, understanding the population at risk, and making sense of the data coming back from clinics and hospitals, all of this is absolutely embedded in the context and the population in question, and local knowledge becomes key. And I think when we talk about diverse perspectives, all of that must be grounded in local contexts, as opposed to being imposed from academic institutions who may or may not understand what's going on in the real world. So why do we need dynamical models or mathematical models, which are kind of different from the statistical frameworks that we might use for non-communicable diseases, for example? So non-communicable diseases like cancer and diabetes and so on, in those cases, we can think of disease as individuals going through their life, having different exposures, and the population outcome, so what you expect in a given population, is kind of what you would expect as the average outcome of lots of individuals. So it's like everybody playing their own pinball game, right? Infectious diseases are different because your outcome depends on the outcome of everybody around you. So individual risks require an understanding of the dynamics of the population. So we need a slightly different framework for actually conducting epidemiological analyses for infections. So the other thing about infectious diseases is that the time scale on the dynamics of the disease is often very fast compared to non-communicable diseases. So this is a picture showing super spreading events for Sars, which was a virus that hit in 2003. And you can see that these high risk individuals were spreading the disease to many people around them. And it led to an outbreak that looks like this. So this is a classic kind of epidemic outbreak where the cases come up very quickly, often following an exponential growth phase, and then come down. And so the timescale is rapid, and we need to be making decisions, and models are often useful for that, especially when the disease is something we haven't seen before, as in the case of SARS-CoV-2. So the basic framework that we use for most of these dynamical frameworks that you will be learning about during your workshops are these SIR models, which gained traction last year when the epidemic started. A lot of people started building these epidemic models. And I think that the key to understand here is that the basic parameters of this model include these three important parameters: the probability of transmission given contact. That is, if somebody coughs on you, what's your chance of actually getting SARS-CoV-2? The duration that you are infectious for, so how long does the illness last? And then this parameter here, the probability of infectious contact. And a lot of this talk, I'm going to talk about how this parameter, the probability of contact or the contact rate, is really one of the hardest to measure, but also one of the most important for understanding contextual differences between populations and why we need to adjust our model to the local population in question. So these kinds of models tend to lead to these sort of traditional epidemic curves like this, where the infection starts off and it spreads rapidly through the population. And then it peaks. And usually, if you just leave the model to run without assuming anything about interventions or vaccines or anything, the epidemic goes away because the disease runs out of susceptible individuals. So it's kind of like a forest fire where the fire just runs out of trees. So the epidemic goes away and we have people becoming immune in the population. And so analysis of this very simple framework has led to a lot of useful results that we can use for understanding infectious disease. One of them is this threshold condition that I mentioned earlier, the basic reproduction number. And if you think about those three parameters I told you about, the contact rate, the recovery rate, and the probability of transmission given contact, they combine to define the reproduction number in this way. So you multiply the contact rate by the probability that a transmission can occur when a contact happens, and that goes into the numerator. So when those parameters are large, the reproduction number is large and the growth of the epidemic is large. And obviously when the recovery rate is quick, so people recover very quickly, that means that the pool of infected people is going to go away fast, and the reproduction number is inversely proportional to that. So these simple parameters go into the reproduction number. But again, I want to focus this talk, a lot of it, on this parameter K, the contact rate, and how we think through measuring it and making sense of it in different contexts. So if we just think about this formulation for the basic reproduction number, we have the probability of infection given contact, or how contagious something is, the duration of infectiousness, so how long you're sick for, and the contacts per unit time. And if you think about your own life and try and estimate the number of people you've come into close contact with over time, it's kind of hard to get an accurate estimate of that. And that's often the case. But our interventions are related directly to these parameters in the model. And that's how we can ask which kind of interventions might work and how we can combine them to effectively reduce transmission. So masks operate to reduce the probability of infection given contact. Tracing people and trying to isolate them and make sure that they're quarantined is going to reduce the duration that people are infectious to others. And then social distancing and lockdowns, the whole point of those interventions is that they reduce the contacts per unit time. So the contact rate is reduced by these non-pharmaceutical interventions. And that's that underpinned all of the social distancing and lockdown policies that were put into place around the world when the coronavirus hit last year. And these very simple models can give general findings that are helpful. So one is we can kind of mathematically write down the relationship between the reproduction number and how many people we expect to be infected over the entire epidemic. And it's related in this nonlinear way. And so if we indefinitely reduce the reproduction number through social distancing, then we will ultimately reduce the final epidemic size. And that's a general finding of this kind of model. There's been a lot of discussion of herd protection, and that comes out of the model as well, even these very simple ones, with the idea being that if sufficient numbers of people are immune due to a vaccine or due to previous infection, then we can protect the people who may not have had a vaccine or have not been infected. So we can protect susceptible people by sort of surrounding them with people who are already immune. And there's a relationship between the basic reproduction number and the parameters in our model and how many people we think need to be immune in order to stop the disease from spreading. And that has been the argument that you may have seen in the media and in policy around this idea of herd immunity and what the threshold for herd immunity really is for SARS-CoV-2. So here you can see again, we've got this non-linear relationship between the basic reproduction number and this threshold where we're now protecting people who are still susceptible. So the lower the reproduction number, the fewer people need to be immune in order to stop outbreaks. And there's of course this big debate about what that threshold is going to be. And then I think one more kind of relevant finding from the very simplest models is the relationship between epidemics and the population size. So in general, and this has been a finding since 1960 when Bartlett sort of coined the term critical community size. But the idea is that, as I mentioned before, like with forest fires, you need enough people in a population to sustain the spread of a disease without it dying out. And so there's a strong negative relationship between population size and fade out of the infection where there are no cases. So this is actually for measles, but it shows that when you get very large populations, you hardly ever get fade out because there are enough people to keep the virus circulating. And if you map that onto the US, for example, you can see where to expect persistent spread of diseases and where you might get fade outs. And I think that we've seen a very big difference between urban and rural spread of coronavirus. And some of this is to do with these basic mechanisms that are explored in even the simplest models. So when we have our model framework like this, in order to actually apply it to the real world and try and understand what it means for the spread of infection, we have to also know, in addition to these parameters, we also have to know the state of the system. So how many people are in the S, the I, or the R compartment? And this is where data starts to be a major issue. So for SARS-CoV-2, for example, we have confirmed cases, but in a lot of times, the confirmed cases is very unreliable because testing capacity has been an issue since the beginning of this epidemic, not only in low-income settings and resource-constrained settings, but also in high-income countries, including in the US and in Europe. So almost everywhere, the confirmed cases that we're seeing, for example, in the New York Times published cases and so on, those are only a subset of real cases. Of the actual epidemic size. And they are, of course, lagged as well, because we know it takes about 5 days for you to get symptoms after you contract the virus, which means that the actual transmission event happened before the cases start to be confirmed. We also have data on hospitalization, so how many people are hospitalized with COVID-19 disease. And those numbers tend to be a bit more reliable because we don't have people that don't have any symptoms and not getting tested. So we kind of know how many people have COVID-19 in the hospital. And of course, COVID-19 deaths have occurred as well. And the deaths themselves are usually more reliable in data sets, but even deaths are not accurately counted all the time, and they're not accurately counted anywhere. So we have some challenges with fitting our models, certainly with confirmed cases, but even with deaths, we have some issues. And the reason for that is that our testing capacity and testing criteria have been variable over time and continue to be insufficient to truly capture the epidemic. So here, if we have our susceptible, infected, and immunes, testing capacity is variable, and it's only going to capture some of these people. So that's going to be a very much a health system specific number, and often vary locally a lot. Of course, as more and more people become immune, there is an additional question of who is now protected, who needs a vaccine, are we close to herd immunity? And those questions are very challenging in many cases. We can do seroprevalence surveys where we look for antibodies in people and try and estimate that. And I'm going to talk a bit more about how those kinds of approaches have highlighted who we've been missing in our health systems. So both the parameters in the model and the state variables, there's how many people are in each compartment, can be challenging to measure, but even the simple models are going to be useful to give us general principles about mechanisms and what we can expect. But in order to apply these models to real world settings in a way that is translational, that is able to be applied to policy and decision making, we have to incorporate the specifics of a given population. And, you know, every country is different, but even within countries, we have a lot of variation. One of the most important differences between countries that's going to affect how many people are hospitalized and die from COVID-19 is the age structure of the population, and that has to be taken into account. So these graphs show the age structure of 3 countries, UK, India, and Nigeria. The way to look at these graphs is to basically, the women are in pink, the men are in blue, which is very sexist, but whatever. And then we have age categories going up the y-axis. And then we just look at what fraction of the population is in each age group. So in the UK, for example, we have this fairly flat distribution of ages into old age. In India, we have a sort of a bulge here around young people. And in Nigeria, we have this strong pyramidal age structure where we have many, many people in the youngest age categories and very few in the oldest age categories. Now, if you look at the fraction of the population in the high risk group for clinical COVID-19 and death, this leads to very different predictions for any modeling result, right? Because in Nigeria, only 3% of the population are expected to have these strong infection fatality rate increases. So it's only going to probably impact a smaller fraction of the people. Whereas, nearly half the population is under 20 in Nigeria. And so from a modeling and data and analysis perspective, taking into account these big differences between countries is going to be really important, and I think has led to some confusion in understanding what to expect in different places. Another major feature of the contact rate that we talked about before is household structure differences. Now, we know that, even within countries, different neighborhoods have very different household structures, with some having overcrowded households and multi-generational families living under the same roof, and other areas, often higher socioeconomic status people having much smaller households. You also have between country differences here. So this just shows the distribution of household sizes in these 3 countries. And you can see that in the United Kingdom, for example, the vast majority of households actually only have 1 to 3 people in them, whereas in India, most houses have at least 4. And so when we're thinking about trying to model and understand the dynamics of these diseases, we have to take into account the context and the national context in terms of the demographic structures that are important and the specifics around what households look like and how people's societies are structured. And when we think about all of the factors that could impact the spread and the transmission of SARS-CoV-2, and we want to take our models from the very simplest models that just have 3 parameters and 3 state variables, and we want to start to ask questions that are more nuanced and context specific, we have to start taking into account information that really is only understood well by people who are in that local context. So when we talk about the importance of diverse perspectives, this is a scientific imperative. In order to get the models right, we have to understand the local risks and the local patterns of variation that will determine those risks. So in this paper, for example, the authors were looking at the relative epidemic risk from SARS-CoV-2 across sub-Saharan Africa. And they wanted to capture both the direct burdens, as in the mortality rate, people dying, as well as the indirect burdens, which might be disruption to routine health services. And then think about factors that might influence the epidemic pace, including the frequency of introduced and imported cases, as well as the transmissibility of the disease in that place. And they identify a multitude of risk dimensions that we need to understand: demography, the pattern of comorbidities in the population, the climate in that place, what prevention possibilities there are, whether access to care is evenly distributed, and how mobile people in the population are. And I'm not going to go through all of this, but the reason I want to highlight it is because all of these things, right? So in sub-Saharan Africa, sometimes there are fewer medical facilities, fewer physicians, there may be other comorbidities that are not included in models that are relevant for the US, for example, as well as different demographic structures. There's also a whole range of different parameters and features that are going to be relevant for our transmission model, including our reproduction number estimates. So the reason I'm showing this slide is to show you just how complex it can be to make a model relevant for a particular setting, but also how important it is that we have local understanding and local knowledge of what those factors might be and which heterogeneities we need to include in our model. We're trying to create, generally, there's a rule of thumb that says we're trying to create a model that's as simple as possible and no simpler. And part of the art of doing mathematical modeling for infectious diseases is understanding how and when to include heterogeneities that are important. And I think this is why we must include local knowledge in the development of models and in the analysis of data coming from health systems. Because if you don't understand these local features, you may misspecify your model and you're not getting useful results. One of the most important features of these models that I talked about before are these contact rates that underlie everything about how quickly you expect a disease to spread. and age structure of a population I've talked about before, but also the patterns of mixing that determine how a disease will spread are very context specific. We often use age structured contact matrices to try and understand the spread. So these data are from Italy and Germany, and they are the result of a survey where you ask people, how old are you? And who have you contacted in the last day or week? And how old are those contacts? And then, so the person responding to the survey is on the x-axis, their age, and the ages of their contacts are on the y-axis. And the heat map here is colored so that the red blocks mean more contacts, and the gray and white blocks mean fewer contacts. And you can see that there's a very big difference in both the age structure and the frequency of contacts between two countries in Europe. And these types of structures are going to determine how you predict a disease will spread in your model. And they can be used to highlight how those social differences are going to impact the epidemic potential of the disease. And really trying to parameterize these models with the contact rates is one of the biggest challenges that I think that we've had, and it's been challenging to make models context specific in a meaningful way, because measuring the contact rates is sometimes challenging. So Aisha Mahmood, who's a former member of my group now at Berkeley, she looked at this from the perspective of non-household contacts. So they sent out a bunch of surveys using Facebook to ask people about who they were contacting. And they looked at the demographic features of those people and how they responded. And what they found, and this is just for the US, what they found is that contact rates and response to interventions, and I'll cover that in a bit, show variation by geography, by gender, and by race ethnicity in the US. So here we have in this graph, we have it among different age groups. We have the number of non-household contacts. So this is who do you contact, how many people do you contact outside of your household? And it's broken down by gender here. And you can see that in general, males have more outside contacts than females. Now they did a series of different waves of this survey, and they looked across different cities in the US. And then they segregated their data by race, ethnicity, and by place. And these different colors represent the different waves of their survey. So as the epidemic progressed across 2020. And what you can see is that the number of non-household contacts is different in different racial and ethnic groups, and it's different in different cities. So as we have data to be able to ask questions that are relevant to different demographic groups that are responsible for transmission in different ways, that we have to understand and also incorporate into our models if we want to make sensible interventions, we need to have data that's disaggregated in this way, because there are important differences, as you can see here, on the national level between these different groups. And if we think back to our R0 estimates, since R0 is linearly dependent on the contact rate, if we have different places and different demographic groups that have different contact rates, what that means is that we have different reproduction numbers for the same virus in different contexts. And understanding how an epidemic is going to progress requires an understanding of the social fabric on which it's spreading. So one of the ways that we can start to gather data on mixing patterns in general is through the use of mobile phone data. And this just shows across the world the fraction of adults who say they own a phone. This is from 2018, but we're all aware of the ubiquity of mobile phone use now. So we can use this data, as Rodelyn mentioned at the beginning, to try to start to answer public health questions, and in particular, to parameterize the models, the SIR models that we want to use. So this is just an example. So if you're using your phone and you're on Facebook or something like this, then you're leaving a digital trace behind you. And if we can aggregate that data in a way that protects privacy of the people who are producing it, and this is a big issue and a big area of research, but if we can do that, then we can start to answer questions about what makes neighborhoods different in terms of their mixing patterns, and can we measure that over time? So my group has been doing this for some time, including in the context of COVID. And of course, there are the obvious questions that you can ask with this kind of data, like what were the changes in long distance travel before and after the lockdown, and how might that impact the spread of the epidemic? And this graph just shows the average daily transitions measured using mobile phones before and after, a month before and a month after March 16th of last year. And you can see there was a big reduction in long distance travel. And that's obviously going to have a major impact on what we predict about the spatial spread of this virus. But the other thing that you can start to see in this data is that we've seen a big urban-rural shift. A lot of people have left cities, and they left cities last spring, and some of them haven't come back. So this just shows for a bunch of different cities in the US, the emptying out of their urban populations. This y-axis is measured from Facebook data, and it shows the percent change in the nighttime Facebook population. So because we're looking at the nighttime population, we think it's indicative of residency in that place. And what you can see is that these cities have emptied out once the lockdown happened, and people have moved from urban to rural areas. In fact, we've seen this around the world in many places. But what's interesting to me is that we can start to pick out exactly who might be leaving. If you look at New York, for example, and you look at the percent change in that nighttime Facebook population, you see that by far the most people leaving has been Manhattan here, whereas the surrounding neighborhoods haven't seen the same emptying out. And so we suspect that probably affluent people in Manhattan who had second homes or were able to go to the countryside did so, whereas people in surrounding suburbs were not able to leave and they remained. In fact, when you start to look at the correlation between these mobility patterns measured by mobile phones and the prevalence and burden of disease, you see similar kind of patterns emerging. So this was a study led by Jonathan Grad at HSPH, looking at SARS-CoV-2 in pregnant women delivering at hospitals around New York. Pregnant women are a good sample because they're kind of random, right? They're not biased as other samples might be. And what you can see is that the estimated fraction of women coming in with SARS-CoV-2 was very high in the areas surrounding Manhattan, but not Manhattan itself. And when you compare this to the mobility patterns that we measure using mobile phones, you see a very strong relationship where people that stopped commuting, this last point is Manhattan, showed low prevalence, and people in neighborhoods that continued to commute had very high prevalence. So what this says is that essential workers, people who could not afford to lock down, people who could not work from home, had to keep commuting for work, and they were disproportionately burdened by this virus. And this burden is not just been in infections. When you start to disaggregate data by race, ethnicity, as well as by location, you can start to see patterns that give us some insight into what's been going on. So this is data from the US in general, and this is a statistical method that looks at excess deaths compared to reported COVID-19. So the idea is we're not capturing all the deaths due to COVID-19, but what we can do is look at the death rate in previous years at that time of year and see how many deaths on top of that are occurring. And that can help us estimate excess deaths, which encompasses not just COVID-19, but also excess deaths due to interrupted access to care and so on. And what you can see when you look at that in a local way is that we've had massive excess mortality in Black and brown communities in particular. So this is data from Cook County in Illinois. And if you start to look at the increase in expected mortality in different age groups in Black and white communities, Black and white people, sorry, you see much more excess deaths in Black people compared to white people, especially in this age group, 75 plus. So the important thing here is that we need this disaggregated data in order to be able to disentangle mechanisms by which people are being disproportionately burdened by an epidemic, as well as dying more often from it, and also to make sensible models. So we can't make accurate predictions, we can't accurately understand the epidemic dynamics if we don't have sufficient resolution on our data. In fact, as all of you probably know, this disproportionate burden of infection and death in non-white communities is something that's happened all across the country, and disproportionate infection and death rates in poorer populations has happened all around the world. And again, because we have the data broken out by race ethnicity, we are able to start to calculate how much worse it is for some groups compared to others, and try to understand how the epidemic might progress in different communities. And understanding data, understanding nuances in the data is essential to make sense of this. So if you just look at this in a coarse way, right, this shows a map of the US, and this is the result of a survey where respondents are asked how likely they are to wear a mask. If you look in a coarse way at how the distribution of those respondents are around the US, you can see some sort of geographic patterns popping out, and those geographic patterns seem to be related to intersecting demographic risks. So this map on the right shows the intersection of risks from poverty, so percentage of households under the poverty line, and the population over 70 years old, so they are more at risk of dying. And you can see that there are sort of rough correlations between these groups. And I think what we've seen in the last year is a lot of blame and a lot of sort of finger pointing about who's to blame for all of this, about wearing masks and so on. And again, the important thing here is to take a scientific approach and to use disaggregated data sets to try to understand what's going on. When you look more into that survey and you ask, okay, let's look at respondents' likelihood of wearing a mask by gender and by race ethnicity, we see that women are more likely to wear a mask than men, or say they are more likely to. And we see big differences in race ethnicity. So we see that in this survey, Black and Hispanic populations are more likely to be wearing a mask compared to white populations. So there is nuance, and you would not be able to capture it effectively if you didn't understand how to look at data and make sense of it, and how to parameterize your dynamical model effectively to make predictions about what might happen. So this isn't just unique to the US. In fact, all over the world, we've seen disparities in the burden of infectious disease. And this is an interesting study. This is from Mumbai in India, and they looked at seroprevalence. So this is how many people have antibodies to SARS-CoV-2 in different parts of Mumbai, a large city in India. And they divided up by slum regions and non-slum regions. And so here you have, in blue, you have the male rate, so the male prevalence of antibodies, and in red, you have the female rate. And they've separated it out by non-slum regions, where you can see still quite high, but around 20% of people have had the virus, compared to the slum regions, where a huge fraction of people were seropositive. So so this study kind of highlighted the disproportionate impact in slums compared to non-slums. And importantly, it showed that the government's narrative about who had been affected and the official case counts were a misrepresentation of reality. They had not captured this important heterogeneity, and they had failed to account for the fact that there was a disproportionate burden of the disease in slum regions. And then this is a study from Pamela Martinez and some colleagues, where we're looking at socioeconomic status and the death rate from COVID-19 in Santiago and Chile. So here, this is a map of Santiago, and the neighborhoods are colored by SES, by socioeconomic status. And we looked at the deaths per 10,000, and you can see a very strong relationship between socioeconomic status and deaths, where poorer neighborhoods have a much higher burden of mortality than richer neighborhoods. And the interesting thing is that we can start to use data to understand what was going on here in order to prevent damaging narratives. So if you look, for example, at the relationship between socioeconomic status and the average number of tests per day and the timeliness of those tests, we see a strong relationship. So people in rich neighborhoods were not only getting more testing, they were also getting rapid turnaround times on their testing. And so there's a health system element that systematically discriminates against poorer neighborhoods. And when you look in the mobility data that I was talking about, what you can see is similar to what we saw in New York. These lines show the reduction in mobility measured by Facebook data, by socioeconomic status. So the dark pink are the lowest, the poorest neighborhoods, and the green is the highest neighborhoods. And these dates show when the full lockdown occurred. And basically we see what we saw in New York, which was poor neighborhoods were unable to lock down to the same extent as rich neighborhoods. So with these new data streams and with disaggregated data, we can start to disentangle the mechanisms that is driving the dynamics of the disease and find answers for why we might be getting what the mortality, differential mortality rates. In this case, because in poor neighborhoods, people couldn't lock down and they had poorer access to good testing and healthcare. So here again, by having a nuanced approach to combining data sets and having access to disaggregated epidemiological data, we can build up an evidence base by which policymakers can start to address some of these inequalities in a way that is grounded in rigorous science. And if we look back to kind of these three roles of modeling, I think, the whole, I hope what I've shown you is that in each case of these studies, the important thing, even if you're using simple models to understand mechanism and estimate things, is that you have understood the local context sufficiently that you know which variables you need to measure. So I think that there is, quite apart from the moral piece, which I'll talk about in a minute, but there is a scientific requirement for diverse perspectives, because we have to understand how data is being generated, who we have in our data, how we need to disaggregate it, and how we interpret it in context. So models have to reflect the important heterogeneities for any research question. So by definition, we need diverse questions that reflect the reality of the context we're trying to capture. And disaggregated data is key to this. So without data on poverty, race, any other heterogeneity that's going to change the dynamics of our model, you can't measure some of these mechanisms that are impacting the populations that you care about. And without evidence, you can't do effective advocacy and or make policy decisions that make sense. And I just want to say something kind of personal. So Nishant Kishore and others in my group in 2018, after Hurricane Maria in Puerto Rico, we decided to go and try and estimate mortality due to the hurricane because it hadn't been done effectively, and policymakers were still failing to provide the support to people in Puerto Rico who desperately needed it. And we knew, because our friends in Puerto Rico were telling us that the death rate was just much, much higher than the official count. So we put together this Hurricane Maria study, which was a survey study where Puerto Rican students from our collaborators went and asked people about deaths in their households. And then we used a statistical approach to try to estimate what that would mean for the overall mortality count. This study was done in 3 weeks. It was done on a budget of less than $30,000. And it came out in the New England Journal, but also in the press. And it had a huge impact. Not only did people feel validated that their deaths had been counted and there was this memorial on the Capitol steps in San Juan, but also it provided them with the means to, for example, access funds, access aid. These counts are important for people's lives and ability to be resilient. And I think for me, that was a real turning point where I realized that sometimes it's about collecting the data you care about and doing a rigorous evidence-based approach in order to move policy along and in order to prove something that is meaningful. And so this really, I think, to me, the reason that diverse perspectives, one reason that it's important is because we all care about different things, and science is a tool to collect data and show evidence in a way that can really change policy and can have an impact in people's lives. So I'm not going to talk about that now because I don't have time. But I want to point out that this idea that disaggregated data is important is actually kind of recent. This was a 2018 policy brief about why it's important to have diverse data. And this is, in 2019, it was the first time that WHO actually disaggregated by sex the global health statistics. So without disaggregation, we can't start to ask these questions, but I think that the world is changing and we're starting to recognize how important this is. So I've talked about science. I'm going to end by talking about diversity in academia, which is another part of this question of why diversity and perspectives are important. I want to point out that this is my personal opinion, so you know, take it as such. We're still a really, really long way from having a sufficiently diverse faculty, frankly, in almost every subject. So this just shows the fraction of men in different fields over time, and this shows the fraction of white scholars in the field. And you can see it has come down slowly, but we're still not there. And this stops at 2010, but we're still very far from where we need to be. This is Harvard University, my own institution, looking at tenured faculty from 2008 to 2018. And you can see that it's basically stagnant with respect to women and underrepresented minorities. So we have a long way to go. In health, we also have a long way to go. So it is generally true that global health is delivered by women, but it's led by men. And you can see that these categories of health leaders, women are severely underrepresented. And when you get to the actual long-term care workforce, it's 90% female, as well as healthcare workers and social workforce as well. So this needs to change, no question. The MIDAS network has done some comparisons, this from Jess and Wilbert and their group, looking at the representation of different ethnic, race and ethnicity groups. And you can see that we are not doing great in terms of Black and African American colleagues. We're doing better in other places, but we still have a long way to go. And my own perspective, my own opinion is that there's a problem with the diversity statements that a lot of places are putting out, because I think these narratives are incomplete. So they often read like this. They say, we have, you know, unique perspectives and talents are important. We have not done well, and we are actively working to improve this, and we celebrate the multiple dimensions of diversity. This is absolutely critical, but by leaving the conversation there, I think we are limiting what we can do, and we are, in some cases, preventing progress. So I'll try and explain what I mean. So yes, it's true that there is an ethical imperative to increase diversity to reflect our society. But by limiting our discussions of diversity to only that point, we fail to acknowledge the scientific and institutional reasons to increase diversity among our students, postdocs, and faculty. And I think what that does is it creates a culture that hasn't fully acknowledged that we're compromising on our scientific excellence by failing to include and retain the brightest minds in our fields. So what that does, there are kind of two knock-on effects of that. First of all, I think it promotes imposter syndrome among scientists and underrepresented groups, and they feel they don't belong or don't deserve to be there. That's something that I've struggled with. It's something that we all struggle with, but it's particularly felt in underrepresented groups. And I think that this narrative that we need to promote diversity because it's the right thing to do, in some ways doesn't help that feeling. And I also think it can exacerbate the bias among white and or male colleagues about people only being there because they're tokens, rather than reflecting the fact that we have great scientists that just aren't at the table currently. The other thing I think that it does to just focus on this, like we need to do diversity because it's correct, because it's right, is that it forces scientists from underrepresented groups to assume that they have to take up the burden of diversity efforts, which they do disproportionately. And it creates a culture where people expect them to do research only relevant to race or gender, for example. And that limits the possible avenues and interests of underrepresented minority scientists. They shouldn't be assumed that they must be interested in those issues only. They can do anything, and they should be represented in all fields of science. And I think it also creates a perception among other colleagues that they don't have to worry about institutional diversity themselves or research pertaining to underprivileged groups if they have somebody from that group on their faculty. And I don't think that's the case. So I hope that through programs like this, we can start to have more complete narratives around why diversity is important. To that end, there's a lot of evidence out there that underrepresented faculty do more in terms of recruiting minority undergrads and faculty, organizing workshops and so on. This graph just shows that. But also, we know that these implicit biases continue to persist in academia. So this just shows the results of a study where they showed identical CVs, but they changed the name to look like it was from different races and genders. And so for the exact same candidates, this is in a physics department, the same candidate was viewed as differentially competent depending on their race, ethnicity, and gender. And this highlights the complicated intersections of race and gender here, where there are burdens that build on each other and are complicated. Now, of course, this can be discouraging, but I think it can also help people to realize and manage imposter syndrome, because what this says is that we absolutely are missing people from different groups, and they have just as much scientific ability. In fact, they need more to get to the same place as people who are white. So it is discouraging in the sense that we have a long way to go, but I also think it speaks to the fact that by gathering data like this, we have an evidence base with which to change our discussion around diversity. And we need to, for scientific reasons too. So this paper came out and it shows that the more diversity you have in a field, the more innovation comes out of that field. So they did this study where they looked across time and they looked at the fraction of students in different subjects that were balanced by gender and in the same race. And they found that the more homogeneous the student body was in terms of sex and in terms of race, the less innovative the work that came out of it. And so I think there are very compelling reasons that we need to increase diversity in our field. And they are not just because it's the right thing to do. And I think this, one last thing, just to say that I think this parallels a larger conversation in global health. There is a movement now to decolonize global health and try and understand what that decolonization process means. And Seye Abimbola is one of the kind of pioneers in this field. And he wrote, "What we know as global health today emerged as an enabler of European colonization of much of the rest of the world. And even today, global health is neither global nor diverse." And he asks us to try to imagine a future global health where we've removed the supremacist remnants of colonization from how we conduct it. And so I think this is an exciting time to be having these conversations, not just in the context of our field in the US and in Europe, but also in the broader context of global health. How do we reach for equity, not just in health outcomes, but also in the science behind how we study those health practices and health outcomes. So I want to encourage you to get involved, because I think we are in a very big transition in the field and in academia and around the world. And I think that we need to have as much input from as many different people as we can, because we will not be able to face the pandemic threats that are inevitably coming down the road without broader perspectives. So I'm going to stop there. Thank you very much for having me. I'm really happy to be able to join today, and I'm happy to answer any questions.
Thanks, Carolyn. Really nice to hear the very data-driven approaches to looking at diversity in modeling as well. We are a bit over time, so I think we'll hold off of questions if that's okay. A lot of the people that asked questions are in the conference, and a lot of the questions